Hello, and welcome to Fade Out Depression. I'm your moderator, Tabitha Washington. We're so excited to bring you another program in a Fade Out series. This time, we're partnering with barbers in the Philadelphia area to raise awareness about depression in Black and Hispanic communities. Barbershops have proven to be a staple in Black and Brown communities by providing a safe space to discuss anything ranging from politics, religion, pop culture, and even healthcare. This time, we're going to be working with 5 Philadelphia barbershops in the area to provide education about depression as well as offer screenings. If you would like to participate in this program as a referral clinician provider, all you have to do is email twashington@dkbmed.com and let us know that you want to be part of the Fade Out program. And here are our faculty, Dr. Lisa Harding and Dr. Nathaniel Bafo-Mensah.
Hello, I'm Dr. Lisa Harding. I'm a board certified psychiatrist and an expert in treatment resistant depression.
Hello, I'm Dr. Bafo. I'm an attending physician. I work as a hospitalist and a primary care physician.
And here are our faculty disclosures. This educational activity is supported by an educational grant from Takeda Pharmaceuticals USA Incorporated. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Here are our learning objectives. Discuss variation in depression diagnosis and treatment among individuals from racial and ethnic minority groups. Develop strategies that support treatment adherence and adequate response to treatment in people with major depressive disorder. Apply approved agents for MDD to treatment plans. And now I'll turn it over to our faculty.
So the first part of this presentation focuses on disparities in the diagnosis and treatment of major depressive disorder. To even have that conversation, we need a solid understanding of three terms that are often interchangeably used, but aren't really synonymous. And those terms are race, ethnicity, and ancestry. So race is a social construct based on perceived physical attributes. So it could be skin color, hair texture, facial features. Ethnicity refers to shared cultural elements like language, religion, nationality, and ancestry is more about genetic lineage and geographic origins. For example, someone being of West African or North European descent. When we blur these together, it makes it really hard to understand, talk about, and treat major depressive disorder accurately. Um, Understanding race as a social construct helps providers avoid assuming that certain groups of people have innate biological vulnerabilities. And those assumptions, those assumptions can sometimes contribute to the overdiagnosis of severe conditions like schizophrenia in some groups and underdiagnosis of more common conditions like depression in the same groups. Ethnicity reminds us that culture shapes how depression presents, and that knowledge can change how we discuss diagnosis and treatment in a framework that people will respond to based on their background. Ancestry, to a limited extent, can inform things like pharmacogenomics, and to a very limited degree can predict antidepressant response, but that's just one piece of a much larger picture. So in research, if we use these terms inaccurately, we end up with skewed data that sometimes supports biological racial differences, when in reality, what we're measuring is structural inequities, which undermine culturally responsive care. One key point that I want to make here is that when we look at human genetics, the variation across populations is about 0.1%. And so there's actually more genetic variation within racial groups than between them. And so that pretty much debunks the idea of a racial biologic basis for major depressive disorder. So next, we'll discuss diagnostic criteria for major depressive disorder. The DSM-5 defines major depressive disorder as 5 or more symptoms that meet criteria. So those would include things like depressed mood, diminished interest or pleasure in activities, change in concentration, changes in sleep, appetite, guilt, etc., as kind of listed in the slide below. Happening for over 2 weeks, that is clinically causing a change in function and some degree of impairment. And this has to be unrelated to substance use or other medical conditions. And I think one of the most important parts of that definition is the last piece, is that the symptoms that your patients are experiencing cannot be better explained by a medical condition or by substances. So I think this is where thoughtful, good quality clinical care really matters, because a lot of medical issues can either masquerade as depression or overlap with it. So in clinical practice, some of the common ones I see are thyroid disorders. So hypothyroidism can look like this. People can come in fatigued, with weight changes, impaired concentration, slow thinking, etc. People with anemia or multivitamin deficiencies can also present pretty similarly with tiredness, fatigue, weakness, feeling socially withdrawn, or not feeling as interested in activities that they used to enjoy. So when someone screens positive, especially if it's a new diagnosis, it's really worth asking, is there something else going on that I can treat? The other important piece is the substance use part. So many substances can either worsen or cause depressive symptoms. So alcohol, cannabis use, especially in younger adults. I always ask about vaping, because that can blunt affect, it can impair motivation, it can worsen any anhedonia that they may have. But again, to understand this, patients have to trust us enough to tell us what they're using, and that's not easy to disclose when it feels risky, with financial, legal implications. And so part of diagnosing major depressive disorder really is creating a safe space where patients feel safe enough to be honest with a provider. And then finally, just to add a little bit of nuance to the diagnosis, most patients are not textbooks, so they don't necessarily just have depression and nothing else. Most of the time, people will have multiple overlapping chronic medical conditions. So I'm not suggesting that you withhold a diagnosis of major depressive disorder if somebody meets criteria. What I'm suggesting is that take an extra minute to really look underneath to see what else is contributing, because depression is never presented in isolation. The data for this slide comes from the NHANES study, which is a nationally representative CDC study that routinely screens people from across the country for health conditions, with depression being one of those. So in 2018, they conducted a study whose results showed about similar rates of depression across Black, Hispanic, and white individuals, so about 8 to 10%. So at baseline, at least in 2018, it seemed like the symptom burden for depression was about equal. But when we move into 2019, 2020, and kind of the years around and after the pandemic, we start to see some differences emerging. So there's a 2022 study published that showed that Black individuals were 16% more likely to screen positive for depression compared to white individuals during the pandemic period. And subsequently, there have been smaller studies, particularly looking at depression in Latinx and African American women, showing higher rates of depressive symptoms as well after the pandemic. And this is most likely due to stresses like job instability, loss of family, trauma, that was disproportionately experienced by people in these communities. So the big takeaway here is that, in ordinary times, at least in 2018, prevalence seemed to be roughly equal. But when society is under strain, either through a public health crises or when there's political tension or social upheaval, we start to see racial disparities widening among groups. And this ties directly back to what we discussed earlier, that differences are not driven by biology, but most often reflect social and structural factors. And I think that this slide really brings that home. So when your environment becomes more stressful, communities that carry the heaviest social burden also tend to carry the heaviest mental health burden. Now that we've talked about the prevalence of depression across racial groups, I think the next question is how are these symptoms being diagnosed, and are they being diagnosed at the same rate? And the answer is no. So a national analysis from Blue Cross Blue Shield looked specifically at 3.1 million insured adults across the US, and found that the diagnosis of major depression was 31% lower for Black individuals and 39% lower for Hispanic individuals. Even though we know from the previous slide that the symptom burden is similar. And I think an important point here to consider is that these are insured individuals. So, these are people who have a foot in the door in the healthcare system. This data didn't capture people who are uninsured. Another point I would like to make on this slide is regarding screening. So there was another study that was compiled based on data from the National Ambulatory Medical Care Survey. And so this looks at a snapshot of primary care across the US. And they found that depression screening occurs in a very small percentage of all primary care visits. And when you do a subset analysis and look at things by race, you see that Black patients are significantly less likely to be screened compared to white patients. And this is after adjusting for things like insurance status, age, sex, visit type, and comorbidities. So even when a Black patient that's insured is sitting in front of a clinician for care, they're still less likely to be screened. And if you're not screened, you're not getting diagnosed, and if you're not getting diagnosed, you're not getting treated. So we've already established that screening and diagnosis rates are lower, but it's important to understand why that is happening. So the main factors that we're seeing are stigma, different perceptions of major depressive disorder, clinician bias, access to care, mistrust, and community reliance. So regarding stigma, especially in Black and Brown communities, depression is sometimes viewed as a sign of weakness, something to push through, or something that people handle privately, and that delays help seeking. Regarding perception, some people see depression as a spiritual lens or a moral struggle instead of a medical condition, and that shapes whether they engage with care or not. With regard to clinician bias, sometimes that can be implicit. It could be unintentional, but still harmful. And our biases can sometimes make us attribute someone being withdrawn or tired or overwhelmed to their personality or medical comorbidities. So, for example, a tired, overworked single mother who's late or misses appointments often can get coded in the primary care setting as a difficult or non-compliant patient, as instead of somebody that's that has depression and isn't getting treated for it. Access to care is another big factor. If you live in an area with few healthcare providers, limited insurance coverage, long wait times, etc., your depression is more likely to go unaddressed. And we saw a lot of this, as I mentioned earlier, during the pandemic. Sometimes patients even now have to wait 3 to 6 months to see a therapist or a psychiatrist. And so by the time they actually get the help they need, the crisis has either already passed or even gotten worse. And sometimes the copay for therapy sessions are not affordable, or insurance just simply won't cover it. So all of those become limiting factors that impact access to care. I think a major point here, again, is mistrust and representation gaps. historically, healthcare hasn't always been a safe or validating space for Black and Brown communities. And part of the mistrust that we see today is not irrational; it's historical. Even today, a lot of Black families will talk about the Tuskegee experiments, for example, that occurred in 1932 and went on for almost 4 decades, where treatment was withheld from men that had syphilis, or for example, forced sterilization in the South in the 1970s, or Henrietta Lacks and her HeLa cells, and how her cells were taken without her consent, but went on to be used for major scientific breakthroughs. So for a lot of people, these aren't distant stories; they're lived experience and memories, and that forms a foundation of mistrust for the healthcare system that we see today. Um, Compounding that is the fact that there are also fewer Black and Hispanic mental health care providers. So a lot of patients don't feel understood or seen and aren't willing to be vulnerable. And that affects what they disclose and how they choose to disclose that. And then finally, regarding community reliance, many people turn to friends, pastors, to have those early conversations without really engaging with care in a clinical space. So the big picture here for this slide is that underdiagnosis isn't caused by a single issue, but it's a combined effect of stigma, perception bias, access, mistrust, and community reliance. Next, I want to touch on treatment disparities that we see even after diagnosis. What we can see here is that even after someone is diagnosed with major depression, Black and Hispanic individuals are still less likely to receive medication treatment compared with white individuals. And this is kind of where everything we talked about earlier comes back into the picture. I think the key point I wanted to make here with this slide is that the barriers that we talked about, stigma, perception, bias, mistrust, access, they don't disappear once a diagnosis is made. They continue to influence who gets treated, who accepts treatment, and who remains engaged in care. More supporting data from this comes from Medicare claims data that shows that Black beneficiaries were 48% less likely than white beneficiaries to receive any depression treatment, were 24% less likely to receive the recommended combination of medication therapy and psychotherapy. And we know from treatment and data that combining pharmacotherapy and psychotherapy in treating depression often leads to the highest rates of remission. Yet this data is suggesting that Black patients were more likely to receive therapy alone, while white patients were more likely to receive combination treatment. So even after depression is identified, the treatment pathway still kind of differs significantly by race. And then to add a little bit more to that, a recent JAMA internal medicine study showed that Black patients who screened positive for depression were less likely to receive follow-up treatment compared with white patients. So it just seems that at every step, whether it's screening, diagnosis, and treatment, Black patients are consistently receiving less evidence-based care. And it's really important to understand this framework, especially when it comes to disparities as a clinician seeing a patient, to make sure that we're doing the right thing, that we're screening, that we're diagnosing, and we're treating irrespective of somebody's race. So to wrap up the disparities in diagnosis and treatment section, I want to highlight a few things that can actually help close these gaps. So first, in the clinical space, cultural competency is the foundation. Try to understand your patient's background, their culture, language, spirituality, their lived experience. All of that shapes how we talk about depression and how patients interpret treatment. Competency alone isn't enough. You need cultural humility. And so that means acknowledging that you don't know everything about a patient's experience, making space for them to teach us and essentially being open-minded and listening without making assumptions. And when we bring that into the room, I think patients can sense that, trust us a little bit more, open up and stay engaged in care. And then finally, outside of the clinical space, I would encourage clinicians, providers, researchers to get into the community, get into the barbershops, salons, go to local events, neighborhood gatherings, and talk with people about mental health. The data that we've seen so far from these slides reflect insured populations, but there's so many people who need help and that aren't insured and are not engaged with care at all. And then also be advocates and try to drive policy that addresses the structural barriers that play a major role in screening, diagnosis, and treatment as well. And with that, I'll hand things over to the wonderful Dr. Harding to talk through evidence-based treatments for major depressive disorder.
Thank you so much, Nate. That was such an interesting discussion. I think, as you were going through the slides, I think I was reflecting on the way in which psychiatry, I think, has advanced over the past 40 years. I think the last couple of comments really make me reflect on agency and the patient's ability to sort of engage in their own care. Right now, we are doing a clinical trial that is trying to enroll a diverse population, but it makes me reflect on how do we get population health data after science has really eroded trust with many subsets of populations. And so what we're going to get into talking about is what are these treatments for major depressive disorder? And really, we have had only 4 major classes of drugs within psychiatry over the past couple of years. And in thinking through them, we have our major antidepressants. And the tricyclics and tetracyclic antidepressants, these are the drugs amitriptyline or Elavil, clomipramine, and Afronil, really used in OCD. We call those sort of like the dirtier medicines in psychiatry. And over the years, that was sort of like the big class that everyone sort of went to. And over the years, what we've found is that pharmaceutical companies have developed quote unquote cleaner drugs, meaning better side effect profiles, really targeting receptors and what we thought of as the neurobiology of depression. And we've developed drugs to target those symptoms. So we have our classes, or SSRIs, or SNRIs, or serotonin modulators, and really our atypical agents. And within those classes, we have really figured out what they target. Psychiatry is an amazing specialty that I think riffs off of primary care. So, what clinicians are experts in is that unlike going to the primary care doctor for a cough, a cold, a headache, where you can get targeted drugs for that, clinicians in psychiatry and those delivering care in mental health take words, which are the symptoms, map them back to brain circuits, and we form syndromes. So that's why that rapport that Nate was talking about with you with building with patients is so important, because what it allows you to do is with those symptoms, your expertise lies in uncovering the target circuit. So if someone is complaining of, say, you have a smoker in your office who also is maybe anxious and has poor concentration, bupropion or Wellbutrin might be one of those atypical agents that you hone in on, because those words tell you which circuits you can target. And as you know, bupropion or Wellbutrin is an NDRI. It targets norepinephrine and it targets dopamine. So the classes of antidepressants that we have really help us think through the symptoms that we're targeting. And then later on in the presentation, we're going to talk about even newer agents that aren't listed here. The serotonin modulators really made us start to think. So in that class, we have highlighted trazodone, vilazodone, and vortioxetine. And they made us think through a different target mechanism of how we think about medications by classes and what circuits they start to activate. In thinking about treatment for depression, we have to think about responses and how do we measure responses. It's really easy in general medicine and primary care. If you have an infection, we can check your white blood cell count and we can figure out the course of an antibiotic if it's taking course, if it's taking effect in the body. If you went to see Nate and you were inpatient where he was treating you, he would trend how your lab values are going. We don't really have that sort of sophistication in psychiatry. So it's really your clinical acumen that you're depending on. So when we look at how we treat depression, we're looking at step line treatments. One of the things I really wanted to highlight for you is really what's shown on this slide, that even in minority populations, this really hasn't been studied very well by drug, but what we know that 2/3 of the patients receiving standard first-line treatments with SSRIs actually don't achieve remission and they're at risk for relapse. Treating to remission is something that we really don't think about or talk about in psychiatric care. It's sort of our approach for the last, I think, 25 to 40 years has been keeping the wheels on the bus. And treating patients and these numbers that we measure and that I'm going to present to you, I really want you to take them as an opportunity to see where we are and really be aggressive in thinking about treating your patients to remission as you do with other illnesses. You know, some patients don't respond to adequate trials of antidepressants, second or third line treatments. And then it brings the bigger question of how do we measure response and how do we think about what response is? So on this slide, it's really what I would like to call a mashup of our treatment guidelines. You know, what do we really think about how we approach it? And so we have many guidelines in psychiatry. The reason why I'm presenting to you today a combination of the American Psychiatric Association and the CANMAT guidelines, by the way, all over the world, they have had consensus meetings to put together guidelines with available drugs by region. One thing that I think is noteworthy is that here in the United States, our guidelines really have not been updated since 2015. Those guidelines were written in 2010 and then ratified again in 2015. The APA has not sat down past that date to include any of the newer treatments or any of the newer augmentation treatments that have been approved by the FDA. So the reason why the CANMAT guidelines were included is because those have been updated up to 2024. And why this is important is because, especially in a minority community, these are not cash pay practices. Patients have to use their insurance to access care, and insurance uses guidelines to sometimes dictate stepwise treatment. So the first thing we do is we see a patient, they're diagnosed with depression. Nate gave a really good overview of what those primary and secondary symptoms are in depression. So those first lines, it's often an SSRI and SNRI. And as we go through the evidence, the theme that I want you to hone in on is that there isn't really the 2006 STAR*D treatment algorithm, well, the algorithm that came out of the clinical trial really tells us three major things. Patients that are going to respond to an oral antidepressant will do so very quickly. The more treatments patients get, they don't get better. And the third, and I think really important thing to hone in on, is that there is no treatment that is better than another one. The reason why that exists is because we don't have a litmus test in psychiatry to test a person to see what kind of response they will give to a drug. So these studies really tell us about side effect profiles and the possibility with which a patient can get better. So the patient goes on a first line treatment. An inadequate response, and that is by clinician measuring the patient and then patient reported outcomes. So those are your PHQ-9s, your BECs. On the clinician side, that's either a MADRS or a HAM-D. And then, depending on tolerability, hone in on that, we optimize the antidepressant. And I think sometimes we skip over that part. And I think one of the things that's hardest is that we sometimes read the evidence and think, oh my gosh, this is such a great treatment for our patient. And one of the things we miss is, can a patient tolerate it and will they say it, right? None of us have ever had the experience where we prescribe something and we send a patient home with it, and then they come back 6 weeks later and they're like, yeah, I stopped that in the first week and we never knew. And we never knew why. And those are the opportunities that are missed. And so optimizing the antidepressant really is the opportunity for us to have a conversation with the patient to see if they can even tolerate that increase in dose. Again, we measure that response by clinician rating, by patient rating. And here is where I think the bulk of what I'm going to talk about next, really we have to hone in on. Do we switch to a second line agent or do we augment? Past that, we can do combination therapies or we can move on to what is my expertise, the neuromodulation. One of the consequences of non-remission, patients have residual symptoms. No, we really don't treat to remission because patients with depression, remember back in the 80s when we said HIV had no face. I think about depression in the same way now. Depression has no face. And in that same way, we cannot tell by looking at a patient what remission looks like. There's a lot of judgment, part of reflecting when Nate was presenting. Think about patients who come to you and say, everyone looks at me like I have everything. I have a job, I have a family, and they don't understand why I am depressed. And one of the major things that we don't remember is that depression has no cure. We don't have a cure. I tell patients this is like diabetes. When we get your blood sugar stabilized, the thing we have to do next is figure out how to keep it stable. And that is how we need to start thinking about depression. We have to get patients to remission because they are at an increased risk for recurrent depression and shorter times to relapse if we don't treat them to remission. The cost. One of the things we talk about cost in money, but we don't talk about cost to families. Parents that are depressed cannot fully show up to be there for their children. We talk about the cost of dying early. We talk about living with other chronic illnesses. There's a few studies that show that 75% of patients with depression have other comorbid illnesses, and that includes other psychiatric illnesses. So it's very interesting for us to sit and reflect and think about what these consequences are. Adherence and non-adherence, I wrestle with this within, I think, all of medicine. And I think we don't have a really good understanding of why not only my minority patients, but all patients take or don't take their medicines. I am fortunate because I do neuromodulation techniques and patients show up to the office for them. And I think part of that is because patients tend to stick with two things. One, the drugs that make them feel better, and two, the drug with the least set of side effects. And I think we don't have those conversations with patients. And I think it's been hard to have those conversations in psychiatry with patients because we haven't had, until recently, very good studies for us to say, hey, if you take this drug, you are at X chance of getting better. We haven't had very good conversations with patients about the truths of what our medicines can and cannot do. So that realistic expectation has been missing. And Nate talked a bit about the reluctance and mistrust. And part of overcoming that reluctance and mistrust is telling the truth about the evidence about our meds. And it is a very powerful thing to form an alliance with a patient. talking frankly about the side effects. Hey, this may cause sexual side effects. We don't talk about with our female patients enough about the sexual side effects. The good thing, I think, in my personal experience with my male patients, as soon as they experience the sexual side effects, I'm getting a call, I'm getting a portal message almost immediately. We don't delve into, especially in our minority populations, the metabolic risk, the risk of hypertension, the risk of metabolic syndrome as a whole with most of our medicines. And I think if we have those conversations up front, the topic of adherence versus non-adherence becomes a different conversation. It becomes a conversation about side effects and tolerability of side effects. Early discontinuation. I have this conversation really immediately with most of my patients. So, as you titrate medicines, in all of medicine, as you titrate a specific drug, we have to have the conversation with patients. I think we leave that conversation right at the beginning and we say, hey, in that informed conversation, we have, hey, you can get nausea, upset stomach, you can have a headache. Every time you start a medicine, my advice is you look at the most common treatment emergent adverse events. And as you can see, that's the third bullet point and decide weight gain, fatigue, sexual dysfunctions, almost ubiquitous for all antidepressants. And you have that conversation. And I think also the validations patients experience. I have often spent more time with patients asking them why they discontinued a medication and didn't tell me. And it's because they fear not being believed. And I think that conversation also needs to be had more often in a minority population. One of the factors I think that Nate talked about was the overdiagnosis of schizophrenia and underdiagnosis of depression. So if they are missed being diagnosed, imagine how a patient must feel in terms of telling their symptoms and then being believed as real, one. And then secondarily to that, having a side effect and having it be taken seriously. And that all comes back to why even you are here listening to this presentation today, education. In the same way we talk with education about clinicians, we have to take the time to educate our patients. That is the thing that I think encourages the most dialogue. Tell the patients the truth. Let the STAR*D clinical trial guide that conversation. Tell them for most patients with depression who don't respond to initial pharmacological treatment, we're going to probably need to think about switching it or augmenting it. And let the patient know there's a plan. Giving patients hope, especially in the field of mental health, has about a 40% chance of making the patient feel better. There's studies on the placebo effect. So having the patient know that there is a plan in place goes a long way with adherence. And they'll come back and say, hey, Dr. Harding, I gave this a try. It's time to move on. I got a headache. The nausea was too much. The benefits did not outweigh the side effects that I was having. So I said a lot about initial care. So what do we start to think about when patients really don't respond to our initial treatments? What do we start to think about? So we have actually studied in psychiatry. We have a systematic review of how we switch. So we included in this the monotherapy studies for people with depression who had an inadequate response to an SSRI and SNRI. And if you look at some of the articles that look at the synopsis of the STAR*D clinical trial, one of the things that we know is that the patients who respond to the first line treatments do so very quickly. So in the clinical setting, how do we use that clinical trial analysis to help us? That we know that 4 weeks into a medicine that you are starting to titrate, if this patient is not an early responder, probably start to already have that conversation to let the patient know that there is hope. So there is a study here that we were looking at. We were looking at the indirect treatment comparison of vortioxetine in Trintellix with aglomelatine, sertraline, the venlafaxine XR, and the bupropion SR. And what we found in this, I like to look at withdrawal rates and as well as how well a treatment did, because like in oncology, it doesn't matter how much or how great a treatment is if no one can stay on it because of the side effects. So we look at the withdrawal rates due to the AEs, and it was statistically significantly lower for the vortioxetine group than the sertraline group. And if you have time, I encourage you to read this trial because it's important to think about for the patients, one, who meet remission and who do not, and then how much they can tolerate the treatment. Attrition in clinical trials is open to interpretation. The question remains of if we didn't have the data on the patient, did they die? Did they complete suicide? Were they well and we just never saw them again? And so that's always hard with looking at attrition data. But when you look at the withdrawal due to AEs, because those are actually captured and that they're significantly lower for a drug, we can then start to present these medicines as treatment options for patients. So for those who don't achieve remission with a first-line treatment, this trial showed, and this evidence, that vortioxetine can lead to higher remission rates than switching to other treatments. And it's important to present many options to patients. So even though you may read this clinical trial, the side effects that your patient got may have you skip over an entire class of medicines. And I think Nate said patients aren't textbooks. Patients are also not package inserts for medications. And that's why your relationship with them matters so much. One of my favorite trials is the VASD clinical trial. And it basically included adults with major depressive disorder who had failed one adequate antidepressant trial. And it compared three strategies. You either switched to bupropion, augmented with bupropion, or augmented with aripiprazole. And the key findings really were that only the aripiprazole augmentation was significantly superior to switching. But that has to also be for the right patients. Because when you're looking at what the remission rate looks like, also remember to look at the side effects. So if you had a patient that is prone to akathisia and is prone to metabolic syndrome, you're not looking at this evidence in isolation. And so the bottom line for the trial was that in TRD, or treatment-resistant major depressive disorder, after one failed antidepressant, the augmentation with aripiprazole produced the best remission and response outcomes, outperforming augmenting or switching with bupropion. And the idea here is to realize that you have other tools in your toolbox and really tailor that treatment to the patient sitting in front of you. One of the good things that we saw coming out of this trial as well was that no significant differences were observed for relapse. So you really have a treatment choice here, and that anxiety was more frequent in the bupropion groups. And I encourage you to use this evidence in the same way I do it. If you have a patient that's more anxious, you're probably not going to augment or switch to bupropion. And that is what these trials, these are the little pearls that come out of them. One of the ones is the third bullet, that AEs were more frequent in the aripiprazole group, included somnolence, akathisia, and weight gain. So for a patient who is already struggling with weight gain, already has that internal restlessness, and somebody that is struggling with daytime sleepiness or somnolence, that is probably not the appropriate. Conversely, some people's depression makes them lose weight. Some people's depression makes them somnolent and a little lethargic, and we have that psychomotor retardation. A little bit of activation may work in that patient. So you're globally looking at the evidence, because remember, we use drugs for side effects all the time. So also we should not get caught up in looking at side effects as all these side effects are bad. Think of clinical scenarios where you can use side effects for good. The optimum trial, the core point of this trial was in patients in adults over the age of 60. I can't say geriatrics. My dad is 85 and he's banned that word, so we don't use it. But it evaluated both augmentation and switching strategies in older adults with depression. And in older adults is where we really focus on tolerability and comparative effectiveness across these real world interventions. And so we saw step one here was sort of mirroring the study that I presented before. In this one, we had aripiprazole augmentation, bupropion augmentation, or a bupropion switch. That was step one. And in step two, we looked at a lithium switch versus a nortriptyline switch. And here, the greatest improvement from baseline in the aripiprazole augmentation and the bupropion switch, really we found no significant difference between the other groups. And again, even looking at these percentages, my encouragement is always look at the patient that's sitting in front of you. Are these side effects intolerable, or can we use the side effect for the benefit of the patient? What we're going to look at now is some of these newer agents that I was talking about right at the beginning. So what are these approved agents for major depressive disorder? Vortioxetine or Trintellix was approved in 2013 for major depressive disorder. And here is a systematic review of 15 randomized controlled trials. And in that systematic review, we found that vortioxetine outperformed placebo in terms of response, remission, depressive symptoms. And so that is true for all SSRIs, right? So SSRIs would not have been, and SNRIs would not have been FDA approved had they not outperformed placebo. But these drugs, and this one in particular, Trintellix, performed similarly to an SNRI. And what does that tell us? It comes back to the theme of what I've been talking about. When things perform similarly, we're looking at the remission rates and we're looking at the side effect profile to determine which is the best patient. So fewer AEs were reported by patients receiving vortioxetine than other SNRIs. And for me, Lisa Harding as a psychiatrist, that's really important because with the SNRIs, those are the ones that for me in my practice, patients report brain zaps. They're the hardest medications to titrate patients off of. And so for the patients that I'm worried about, for concerns about tolerability, especially the nausea and getting over, because at lower doses, SNRIs behave like SSRIs. And so vortioxetine may be an option for me with patients. It was not associated with significant weight gain, a very important issue, because I think obesity rates in our country right now are the highest. They actually did a study comparing those two. So we looked at vortioxetine Trintellix versus desvenlafaxine or Pristiq. And in this trial, we looked at people that had a partial response to an SSRI. Vortioxetine was non-inferior for change in the MADRS at week 8. And clinical trials design their efficacy endpoint very differently. But what I want you to look at here is the odds ratio. So an odds ratio of 1.48 in this trial means that patients taking the vortioxetine had a 48% higher odds of achieving symptomatic and functional remission than those taking desvenlafaxine, reflecting a higher odds. It doesn't mean that 48% more patients remitted. You can talk to your patients about it in these same terms. When we look at some of the newer drugs, so dextromethorphan and its combination with bupropion is termed Auvelity. We know dextromethorphan from cough syrup. And it's really interesting because this combination was tried by combining dextromethorphan plus bupropion in a clinical setting to see if it worked the same way. So bupropion inhibits the enzyme that breaks down the dextromethorphan. So the bupropion here was not thought to be a therapeutic dose, but really the combination of the medicine was thought to slow down the metabolism of the dextromethorphan to get its its effect. Its mechanism of action was through the NMDA receptor antagonism, as well as it has some implications at sigma, but that's why it was designed that way. So these two trials that I have up, the Gemini and the Ascend, really answered for us, especially for me as a practicing clinician, because I'm also a researcher, but for me, patient care is what I really like. It answered some questions for us. So the Gemini looked at the combination of dextromethorphan and bupropion versus a placebo, and the Ascend looked at it at dextromethorphan combination with bupropion versus bupropion alone. As I said in the other couple of trials, all antidepressants outperform placebo. So we know that. So in the Gemini, the key takeaways were it produces a better MADRS improvement and higher rates of remission, which we knew. Common side effects, dizziness, dry mouth, headache, nausea. The titration of this medication is really important because it's the first 3 days, it's once a day. And then as tolerated, we in the community, then we decide whether we move it to a BID dosing. You and I both know as clinicians that sometimes it's harder to get adherence, the word that I don't like, when you give BID dosing. So that's something to think about. If you have a patient that historically does not take the second dose of a medication, this may or may not be a choice for them. But in the Ascend, where we compared it to bupropion alone, it also showed a superior MADRS improvement at 6 weeks. The bottom line is across both trials, the combination of dextromethorphan and bupropion called Ability consistently outperformed placebo and the active comparator bupropion. And so again, coming back to my theme, which is the patient in front of you, the side effect profile to determine whether or not they would be really a good responder to this. Esketamine or Spravato, this is a treatment that is done in office. It was approved in 2019 for TRD, in 2020 for major depressive disorder symptoms in patients that are also acutely suicidal. And for me, that is, I think, the most underutilized indication for this drug. And then in 2025, it got approved as monotherapy, meaning it didn't have to be an adjunctive treatment. It didn't have to be a combination treatment. It didn't have to, you could just switch to this and the patient be on nothing else. As monotherapy, that trial showed, and of course it got FDA approval, that it was both statistically significant in producing a rapid antidepressant effect. In fact, at day 2, there were about 3.8 points and 3.4 points greater in improvement over placebo with that 84 milligrams, 56 and 84 milligram groups respectively, with that improvement. It is a cumbersome treatment. It is in office. The patient have to stay in the clinician office for the full 2 hours. So access to care becomes a conversation to have. As with it, it falls into the DRG or the class of antidepressants. So it carries dizziness, dissociation, headache, nausea. And so with that rapid onset, it really proves a viable treatment for patients that have acute suicidal ideation in the setting of depression. This is a shameless plug for myself and my group. I found lacking in all of the clinical trials any data looking at subsets of minority populations. It's great to tell me that there was this overall reduction in a MADRS, overall remission, overall response, but no groups by treatment really looked at subsets of Black patients and how they're doing. And I wanted to figure out, do Black patients do as well as any other race with this treatment? And the answer was actually, if you delve into the devil is in the details. I looked at their PHQ-9s, I looked at their MADRS, and I looked at their Sheehan disability scales. By the way, depression is the leading cause of disability, not only in the US, but worldwide. And that's why the Sheehan disability scale is so important. Black patients did as well as their white counterparts when we looked at them across the MADRS, the PHQ-9, and the Sheehan disability. And their improvements actually maintained during the observation and maintenance phase, meaning Black patients, it's a small cohort. It was just above 40 patients, 41 patients, but none of them dropped out. They stayed with this treatment because it worked. And the side effects were not bad where they dropped out of this clinical trial. And more than 97% of the treatment emergent adverse events occur and resolved on the same day of dosing. When we look at now the typical antipsychotics, and this is a broad group, so I'm not going to delve into too much detail with them, but as a group, aripiprazole or Abilify, brexpiprazole, Rexulti, Vraylar, cariprazine, lumateperone, Caplyta, and Caplyta is added because it was just approved very recently in the past few weeks as an adjunctive therapy for adults with MDD. And as a class, it's been harder to, I think, talk about this, especially in the Black population, because when you think about augmentation and telling a patient, I'm giving you an antipsychotic, the word that is tied to it when they just have major depression has been very hard. And so destigmatizing even the names of these medicines will go a long way. The transparency and truth about the most common adverse events occurring within each one of these drugs and as a class is going to be very important when you have to get patient buy-in. So tell them the truth about the akathisia, the fatigue, the weight gain, the metabolic syndrome, the somnolence, the sedation by each drug. I think it's important because it it gives them that confidence that you're on their side, and it also tells the truth and transparency. You know, most patients will go down the rabbit hole with you with taking a drug that is even a little bit riskier when they believe you. So for my patients that are really struggling and I want and they've tried 12 different meds and we are on the 13th and I say, hey, there is a side effect of a little bit of weight gain, but let's try it and see if you have a response at a low dose. And then I'll talk to your primary care physician about the addition of metformin, and we will trend your A1C and we will look at your lipid panel. Patients tend to trust you and go down that rabbit hole with you. When we look at this next slide is a summary table of the treatment strategies, really showing how effective our two major strategies are, which is augmenting versus switching. How are they in achieving remission for the patients based on all of our landmark studies? And that's the VAST-D, the STAR-D, the Optimum. And when I want you, when you look at trial data, really look at it as options and looking at the side effect profile as well as the remission, because they're both really important. High level evidence summaries really tell us that augmentation tends to outperform in a slightly better, similar to switching, but really look at the patient that is in front of you with the treatment options. So with that, the key takeaways that I want you to sort of sit with, read again, rewind the video, that Black individuals are less likely to be screened for depression in primary care, and half are likely as white individuals to receive any treatment. I know we all struggle with less time with our patients, so we have to think about creative ideas. I have simple things in my waiting room. I have gotten together with many pharmaceutical companies to produce pamphlets and drug leaflets with even Black patients on the covers to sort of start to break down that stigma right in the waiting room. 2/3 of the patients receiving standard first-line treatments don't achieve remission and are at risk for relapse. That is why from the first conversation with a patient, we are screening them and having the conversation with them right at the beginning for what hope looks like and what other treatments look like, so that they know that remission is possible. And that is our goal for them, not just getting them a little bit better. We're trying to change the thinking of mental health, that it is like treating our diabetes, getting that A1C down, is treating the patient to remission. And the questions about non-adherence versus adherence comes back to the responsibility of the clinician to educate the patient and really get the information from them to understand why it is that they don't take their medications. I recently found out from a patient only after they discontinued the medicine that they were rationing it because the copay was too high and that we had to switch to a generic, and then they were fine to take the BID dosing. That the BID non-adherence, as I had thought it was, had nothing to do with the patient forgetting to take the other dose. The patient was rationing the medication without telling me. And so with that, Tabitha, take it away.
I want to thank our faculty for that wonderful presentation.
Thank you so much for joining us. As a psychiatrist, I think I am most appreciative of primary care. 70% of psychotropic medicines are prescribed in primary care, and we don't take time to thank you enough for taking the education to help us in treating all of our psychiatric patients. So thank you so much for joining us.
It's great being able to together this presentation for clinicians out there. I think this barbershop partnership will really make a difference in the communities, and it's what we need. It's meeting people where they're at, and I'd like to encourage as many clinicians viewing this as possible to try to get involved in their local communities and try to meet people where they are, especially if mental health treatment is an area of expertise for you.
As I mentioned earlier in our presentation, we're partnering with Philadelphia Barbers to educate clients and barbers about depression. The Philadelphia area barbers will be educated by the Fade Out team to start conversations around MDD in their communities. They will be provided with a list of clinicians that have completed this education so they can refer their clients to depression screenings. If you are interested in being part of that referral network, please send an email to twashington@dkbmed.com. I want to thank you, our audience, for joining us today. Please remember to click the Claim Credit button on your console to complete the evaluation and claim your education credit. Thank you again.